working okay?
Yeah, that looks good. The invite did say we expected about 100, so I'm just going to let that tick up a bit, although we turned off the lobby, so I'm hoping it won't cut you off if people join.
Okay. Just unshare for a minute.
Hi to all those joining. I just said we're going to give it a couple of minutes. I'm expecting around 100 people to attend, so I'm just going to allow a bit more time and then we'll kick off. Okay, we look like 93 for a little while, so I'll kick off. Hello everyone, thank you for joining us today. For those of you that don't know me, my name's Emily. I'm a senior manager in the earlier diagnosis team, leading our work on FIT in the National Cancer Team. We're delighted you've joined us today to hear a bit more about the BSG and ACPGBI FIT guideline. I'm going to pass to Kevin in a minute to introduce himself and the guideline, but I just wanted to make sure if everyone can put themselves on mute. And to let you know, we will have time. We've left a good chunk of time for questions at the end. So if you could store them until after the presentation or put them in the chat box and I'll keep a note. Also wanted to let you know the session is recorded. So we'll make sure that's on the workspace and available to Cancer Alliances to share. And Kevin's also confirmed the slides can be shared afterwards. So Kevin, I'll pass to you and then I'll keep a note of the questions for the end.
Thanks very much, Emily, and nice to meet all of you today. It's going to be slightly weird for about half an hour when I'm presenting and all I can see is my own slides, and I'm not sure if anyone else is out there, but I won't be able to see if you raise your hand or anything. But I think also if you put questions in the chat, if you think of them as we go along, then I think there should be plenty of time within this session to be able to have a discussion, which I think is really important. And there are always lots of questions. We presented this at the BSG last month. We had I think 3/4 an hour slot, and it ended up being 1 hour and 20 minutes because there was quite a lot of discussion. There's a lot of interest in this, of course. So let me just bring up my slides, and as I'm sure you're aware, this is data from predominantly from developed countries, developed nations. The incidence of colorectal cancer is increasing around the world in developed nations, although the mortality is decreasing, and there's a relative improvement in 5-year survival. Unfortunately, the UK remains on the lower tier of nations in terms of what we're doing in achieving improved survival. And things like the screening program obviously have a very important impact, but a huge proportion of patients are still diagnosed as emergency presentations, about just under 1 in 4, and a large number of patients are still diagnosed not just via the two great pathways it is in England, but also people referred with what have been considered to be low risk symptoms previously, and so predominantly they are diagnosed, the largest group, by GP referral to secondary care, but not just on the two great pathway. This was not the first attempt to develop a guideline for how we apply FIT in the symptomatic population, and as a consequence of that, because of previous failed attempts, we really tried to make sure as much as possible that we applied robust methodology, and BSG guidelines are NICE approved guidelines, which is one advantage, and that's because BSG applies the same standards in developing guidelines as NICE do, and NICE recognise that and endorse the guidelines. And secondly, we felt that it was very important that we had very broad representation, which I'll speak about, and particularly important that representation was very strong from primary care. There are other things going on in parallel, as I'm sure you know. NICE are developing a guideline. The scoping for that hasn't happened yet. It's not clear necessarily what will happen, whether that will be as broad as the guideline that we've produced. But we have included in our guideline all patients who have signs and symptoms of suspected colorectal cancer, and we have not included patients who are on surveillance pathways, so for example post-polypectomy surveillance or screening or asymptomatic populations, including those, for example, with a family history of colorectal cancer. So they're not being included in the scope of this guideline. If we think about the threshold for referral, as you know, NG12, patients are said to have high risk symptoms and should be referred on the two-way pathway. And it is the target is that 3% of these patients will have a diagnosis of colorectal cancer, and the guidelines are reasonably effective at producing a population of people where about 3% have an underlying diagnosis of colorectal cancer, these patients are said to have high risk symptoms. However, symptoms are really poor predictors of who is likely to have a diagnosis of colorectal cancer. And we've been taught this paradigm that actually there are such things as high risk symptoms, but actually, as you know, symptoms are rather subjective, and what constitutes a high risk symptom is really dependent on whether or not the patient is likely to have an underlying diagnosis of colorectal cancer. The positive predictive value of individual symptoms is rather poor. So as you can see here, and this is data derived from the NG12 NICE guideline. Some symptoms or signs are a little bit better, PR bleeding or anemia, for example, weight loss, but most are poor predictors of who's likely to have an underlying diagnosis of colorectal cancer. In the NICE FIT study, we recruited over 10,000 patients from around England, referred them to a great pathway, and we offered them a FIT test just prior to them having bowel preparation, prior to the colonoscopy. And therefore we were able to determine how effective FIT testing was in this symptomatic population referred in the two-way pathway. At a FIT threshold of 2 micrograms, so the lowest detectable or quantifiable concentration of hemoglobin in feces, FIT testing is really an excellent test to detect colorectal cancer, not so good at detecting adenomas, but it is really a very good test for the detection of colorectal cancer, and it's unlikely that we will have any biomarker in any time in the near future that will be as good as FIT testing at doing this or achieving this. Positivity at a very low threshold is almost 40%, and at a threshold of 10, which is commonly already applied in England, there's a 19% positivity, and about 16% of patients will have an underlying diagnosis of colorectal cancer. So if we take a subjective symptom and we add an objective test like FIT testing, then this improves our ability to identify who is likely to have a diagnosis of colorectal cancer and who needs to have tests most urgently, And we can apply our resources more precisely for those people who are most likely to benefit. It has an excellent sensitivity. It may help, obviously, to reduce unnecessary referrals and colonoscopies, and obviously this is very important. However, the main purpose of our guideline and the main rationale was really how effective it was at identifying colorectal cancer. FIT is an objective measure of risk, whereby until now we've been using a subjective and unreliable marker in terms of symptoms. What are the appropriate thresholds? Should we be aiming at 16% of patients should have an underlying diagnosis of colorectal cancer, 3%? Obviously, these are all arbitrary numbers, and we obviously have to bear that in mind. And of course, the other thing that we're all very aware of course, and continues to affect us greatly, we were already struggling with our waiting lists prior to the pandemic. But at the outset of the pandemic, and we essentially were performing no endoscopy at the very start, and although we're back up to pre-pandemic levels of endoscopy activity, there was a 72% reduction in the diagnosis of colorectal cancer in the first few months after the onset of the pandemic, and we're left with significant issues with regard to how we manage capacity and identify patients who have colorectal cancer. So we convened a multidisciplinary guideline development group with representation from primary and secondary care, epidemiology, 2 lay members and research fellows. The representation from primary care were, those of you may well know, Brian Nicholson and Lance Saker. We had a professional guideline methodologist, Joss Kleinen, as I said, we needed to ensure that we had robust methodology, because what we wanted to ensure that we had a guideline which was NICE endorsed and approved, and that would meet the standards that NICE would apply in the development of a guideline, and that the recommendations that we made weren't based on opinion, obviously, alone, and based on the best available evidence. We went through 3 rounds of Delphi, which some of you may have participated in earlier this year, aiming for 80% agreement thresholds. I'll explain a bit more about that in a moment. And we have followed, as I say, standard methodological approaches using the GRADE tool and agreed to methodology. Normally, I mean, I've previously, I was lead for a hereditary colorectal cancer guideline, which was published about 2.5 years ago now. And we did this over about 2.5 years. Whereas because of the urgency and the need to develop guidelines, and one of the pieces of feedback we had, especially from GPs, was that there was a feeling that GPs needed backup in order to deliver this, that they needed a backup of a guideline. There's obviously a huge pressure on resources, and patients who are not being diagnosed with colorectal cancer, most importantly, who we need to identify in order for them to have, to improve their outcomes following diagnosis. And as such, we were told we needed to do this in 12 months. And we had to do this under significant time pressure, but we also could not compromise in any way on the robustness of our methodology. So the key questions that we developed as a guideline group were: should FIT be used primarily in primary or secondary care as an index test? What safety netting approaches should be applied for patients who have a FIT below threshold? And I'd like to say that we don't use the term FIT negative, because it actually doesn't mean a great deal, and it implies patients would be excluded. We wanted to ensure that nobody would be excluded on the basis of a test alone, such as FIT. So safety netting is very important. We wanted to ensure that we had the best available data about the diagnostic accuracy of FIT, and as well as the NICE FIT study that I was involved with, there are a number of other large data series that have published on this in the last few years. And we wanted to identify how useful FIT would be to utilise as a triage tool. And to look at different populations to ensure that we would not be in any way discriminating against any particular population, but also to ensure that, according to age, for example, that how FIT should be used in younger versus older populations, or in different ethnicities, for example. We performed a systematic review. Over 13,000 papers were whittled down to just over 100 papers. And we also included grey literature. This is literature that essentially wasn't necessarily yet published. However, our guideline group was constituted with the leaders from the FIT, major FIT studies around the UK, and therefore we were able to access some of these unpublished papers. The Delphi was a broad Delphi across 4 nations of the UK plus the Republic of Ireland, with the largest single group of people invited and people who participated being from primary care. We had 82 out of 96 respond in round 1, and those who responded in round 2 were invited back in round 1 were invited back in round 2. 62 of 82 responded in round 2, and you can see the breakdown by specialty and by nation on the right hand side. This is the first statement. It seems like an obvious statement, but one of the key issues that I say we looked at was how FIT could be applied and what evidence was available about how FIT was effectively applied in primary or secondary care. So the first recommendation is that FIT should be used by primary care clinicians to prioritise patients with clinical features of colorectal cancer for referral for urgent investigation. We deliberately use the term clinical features of colorectal cancer because we feel that FIT is a useful test to perform alongside almost any referral from primary care, whatever the symptom or sign, with 1 or 2 exceptions, which I'll explain in a moment. This is the flow chart, which I'm guessing that most of you will have seen already. So it starts with a patient who presents to primary care, and if they have a symptom or sign, they have a FIT test. And this excludes only patients with an anal or rectal mass or anal ulceration. And it's important to point out that if someone has an abdominal mass, they should be referred, but a FIT test should also be performed, because the result of a FIT test will impact on how they're investigated subsequently. For example, if somebody has a FIT below threshold, they're likely to have a CT scan rather than a colonoscopy in secondary care. And having that information up front makes that decision very obvious and very clear. Anyone with a FIT of 10 or greater, of fecal hemoglobin of 10 or greater, should be referred in an urgent pathway. And those with a FIT below threshold, there is a nuanced approach to how they should be managed. It's also very important to point out that we felt strongly that patients should not be excluded from referral from primary care on the with symptoms on the basis of the FIT test result alone, because it's only a test at the bottom line, and every test has false negatives, and actually you have a patient in front of you, perhaps in primary care, who has symptoms, and those symptoms still need to be addressed. They don't all need to be addressed necessarily by referral to secondary care, and they don't all need to be addressed if they do go to secondary care on urgent pathways. Some of them can be managed routinely, as they are already currently managed routinely in many cases, of course. What we know is that the higher the fecal hemoglobin concentration, the more likely someone is to have a diagnosis of colorectal cancer. As I said, no test is perfect. These are some tests that are commonly used in primary care to assess whether somebody may have an underlying diagnosis or a suspicion of cancer. And with any of these tests, as you are well aware, there will be false negatives. In about 1 in 10 patients with symptoms with a FIT with a FIT below threshold of 10, there will be a colorectal cancer. However, we need to think about this in terms of absolute risk, and I think this is really very important, because you have we need, what we want to do is ensure that patients who have risk that is higher than someone who doesn't have symptoms is referred urgently. But if their risk is the same, even if some cancers will be missed, actually we will miss cancers in patients who have no symptoms whatsoever. Because we will not be referring those patients. And actually, if you take a population of people with a FIT threshold less than 10, and I'll demonstrate this a little bit later in different ways, and the person who brought them to the consultation who has no symptoms of the same age, the likelihood of having cancer is equivalent. And I think that's really important to point out. So in terms of diagnostic utility, FIT should be used as a triage tool. It's not a diagnostic test, and it should be in a population of people who have symptoms. We're not recommending setting up an alternative screening pathway in an asymptomatic population. And we looked at different symptoms and whatnot, which I'll go into again in a little bit of detail. But essentially, people with iron deficiency anemia should have a FIT test. People with persistent bleeding should have a FIT test. And in fact, if you take people with persistent bleeding, actually, you might presume, and a lot of people do presume, that the FIT test will always be positive. In fact, the FIT test will be negative in over 70% of patients, and therefore referral may be avoided because FIT detects digested hemoglobin in stool, and it will differentiate patients with anorectal bleeding related to piles, for example, from those who are likely to have an underlying diagnosis of colorectal cancer. We also included within the population of patients who should be offered a FIT test all adult patients from age 18 onwards, all patients with low or high risk symptoms, and as part of all adult patients, young patients. If we think about low and high risk symptoms, this is very important. You're aware of DG30, and FIT has been used in DG30 patients for the last few years as well. But this is an artificial divide, and in fact, it's not borne out by the data from the FIT studies that there is, that these populations should be managed differently. In Scotland, they recognise that symptoms are poor predictors of colorectal cancer, and therefore they don't differentiate into DG30 and NG12 as we do in England. And they also in Scotland recognise that GPs are generally quite good at identifying patients who are likely to have an underlying diagnosis of colorectal cancer. I mean, obviously, clinical suspicion or acumen is not adequate on its own, but it's a very important factor in this as well. And in Scotland, they've been using FIT in this way for the last few years. They're a step ahead of England in this respect. But bottom line, GPs need to be backed up by guidance. If we think about the high versus low risk symptoms, what evidence is available? This is from the NICE FIT study, and this is there were just over 7,000 patients with what are categorized as high-risk symptoms according to NG12, and just under 2,000 with what were categorized as DG30 or low-risk symptoms. And the positive predictive value of FIT is equal in both these populations alongside symptoms. So in fact, what we really need to change is the paradigm that symptoms are a good way to detect who has colorectal cancer. In fact, a high-risk symptom is a symptom where the FIT level is above threshold. It's not somebody who has bloody diarrhea. I think that we need to get away from that. It could be somebody who feels a bit tired, or someone who has constipation, or some of the symptoms that we would less associated with colorectal cancer. It's actually someone with a symptom or anemia who has a FIT above threshold. That's a high risk symptom, and this is consistently borne out by the FIT studies in the last few years. The sensitivity and specificity of FIT is consistent across different symptomatic presentations. So in summary, FIT is a highly sensitive test for the detection of colorectal cancer. In meta-analyses, about 9 out of 10 patients are detected with a FIT threshold of 10 or greater. There is equivalence between high and low risk symptoms as they have been called up until now. For paired bleeding, it's a highly sensitive test, and many patients will not need to be referred if they have a FIT below threshold. In fact, over 70%, as I've said. The evidence also supports the use in iron deficiency anemia. We also need to reflect on this issue with colorectal cancer in young people, in people below the age of 50. These are people who would not meet NG12 criteria and do not have access to bowel cancer screening program. And for GPs, we published on this last year. The paper was called "Finding the Needle in the Haystack," because actually I think what GPs need is an objective tool to identify those patients who are under 50 who are likely to have cancer, because otherwise it's, I think, an impossible task. And I often hear about, from advocacy groups or at conferences, or GPs should be referring these patients. But I tend to disagree with that. Actually, I think that it's overall in this population, the number of young people who have symptoms who need to be referred. Actually, what we need is an objective test, and not just to refer every single person who's an adult with symptoms. And I think that GPs have not had any effective tool to apply in this respect until now. This is the data from our paper. The prevalence of early onset colorectal cancer, this is cancer in people under 50 with symptoms, is about 1.5%. And the positive predictive value, if you use FIT, is equivalent to that in older population. It's not as high, and it will not be as high in populations where the prevalence is lower, but it's still considerably higher than it is in DG12 and G12 currently. So we don't need to show this. This is the using a FIT threat or fecal hemoglobin concentration of less than 10 micrograms. These are the number of patients who will have true positive colorectal cancer in orange, false positive in yellow, true negative in green, and false negative in red. These are the patients who will have colorectal cancer where the FIT was below threshold of 10, and this is the limit of detection. So this is even below the limit of quantification. This is not a quantifiable level of hemoglobin, but this is any hemoglobin detected in a FIT test. The results are not dissimilar. There is a slightly lower risk of having a missed cancer, but as I said, actually, if you take a population of people who have no symptoms whatsoever, who are perfectly well, they are as likely to have a diagnosis of colorectal cancer. And we have a screening program, and what we really want to try and do is try and direct people who are asymptomatic towards the screening program, and to expand the screening program. As you know, it's been rolled out to age 50 in England at the moment, and what we want to try and do is gradually reduce the threshold over the next few years, so that more patients are accessing screening across the whole age range. And at the moment, the threshold for referral in the bowel cancer screening program is higher than other developed countries. So we need to be able to utilise our resources more effectively for the benefit of patients. This is another way of demonstrating the same data. This is a meta-analysis from Brian Nicholson. And in his meta-analysis, there were no more additional missed cancers in whether you use a threshold of 7 or 10. So back to the algorithm. This is why we have decided on a threshold of 10, but there will be some missed cancers. You could consider different approaches to this, and we have done. Essentially, there's very little evidence for for a specific test as a second line test to safety net patients, and therefore we need to continue to use maybe a more nuanced approach in this population. We feel very strongly that some patients should still be able to access urgent referral with a FIT below threshold. However, many patients also will not need to be referred, and probably most patients will not need to be referred. Some may well be effectively managed in primary care, as they're already being managed currently. But if a GP is ongoing clinical concern, and I do believe the GPs by and large are very good at detecting, having a level of suspicion the patients need to be referred, but there may be other reasons why GPs might be concerned. And we have recommended that safety netting protocols should be incorporated across services wherever people are in England. And we've signposted to existing safety netting strategies within the guideline. There's some interest in duplicate or repeat FIT testing, and this may be a useful strategy in years to come. However, the evidence does not exist that would suggest that we should be recommending this. Part of the issue is that there's a high level of inconsistency between the results of studies in terms of whether a repeat FIT test is a useful thing to do. Not all tests demonstrate that the diagnostic accuracy is improved by doing this. It's not clear how soon that test should be repeated, whether it should be done on the same patient on the same day on the same stool sample, for example. And I think that what we recommend, and we've brought this across to one of our research recommendations, is that a trial is developed, and I think some studies have already been approved and will be starting in this respect in the next year or so. So what do we do with patients with FIT below threshold? Well, this is a really heterogeneous patient cohort. Overall, their risk of colorectal cancer, we have to remember, is very low. There is no evidence of specific assessment mechanisms. So, detecting an iron deficiency anemia, for example, or a high platelet level, in combination with a FIT below threshold, we haven't yet got the evidence for this. There is an NIHR study which is ongoing at the moment, which will publish hopefully in the next year or two, which will inform this, and it may inform the NICE guideline in due course. But we don't have any data from this yet. Obviously, if someone's hemoglobin is dropped from 14 to 8, you're going to be a lot more concerned rather than if somebody has a persistent iron deficiency anemia, which hasn't really significantly changed over the last few years, and the FIT is below threshold. So there may be, elements of clinical acumen that need to be applied in this population. I think one of the things that is really important is effective communication between primary and secondary care, which obviously goes both ways. Advice and guidance is used in some areas, but I think that that's one example of how communication can occur. I'm not saying necessarily this is the only form of communication which should or could be used, but it's important that sometimes cases are discussed between GP and secondary care clinician. I don't think that's rocket science. Some may be managed in secondary care, and as I say, we've signposted to existing strategies. What should we do in secondary care when someone is referred? Well, colonoscopy is the standard method of investigation. However, patients, CT colonography is a really great test at detecting colorectal cancer, and equivalent, in fact, to colonoscopy. And this is obviously a matter for secondary care services. But we do strongly believe that CT colonography should be more widely available across England, and there's a significant variation and access to this test. And actually, doing more colonoscopy isn't something that is really feasible under current circumstances in England. With resources that are available, we need to think about what the tests could be applied, and I think CTC is probably part of the answer to that. And other tests are under evaluation, cannot be currently recommended. And essentially, these patients, how they are handled in secondary care, may be partially dependent on what resources are currently available, but we should be aspiring towards opening up more CT colonography. With regard to equity and access to care, evidence suggests that FIT is an acceptable test in the symptomatic population. There's considerable indirect data from screening populations, but this is a different population. There's relatively limited data, but there is some data that suggests that FIT is an acceptable test to patients and to clinicians. And we probably do need more data in this respect to see, what the impact is on patients and on clinicians in primary and secondary care as it's rolled out. As clinicians, we should actively, and as managers, we should actively prevent discrimination at any stage in the diagnostic pathway as we are rolling out FIT more widely. And I'm aware that in, most of the country we're already doing this, but actually there may be quite nuanced and quite different approaches, and I think that what we haven't had until now is standardization that this guideline will bring to this pathway. We need to ensure that patients can access FIT so that we can identify those patients who are most likely to have cancer. So in summary, and I've got a couple more slides after this which I'll show you, but FIT is a more objective method of identifying patients who are likely to have colorectal cancer, and therefore more likely to identify patients with what have been called previously, under the previous paradigm, as having low-risk symptoms, or younger patients who are likely to have colorectal cancer. So we're going to refer the right patients and be more precise with how we investigate patients who need to be investigated more urgently. We need to work with NHS bodies in primary and secondary care, and not just in England, but across the 4 nations. And finally, just want to reiterate that FIT is not a sole arbiter of referral. Safety netting is very important, and the patients may be referred in alternative pathways where it's appropriate. We have sections within the guideline about implementation, and this is drawn from the experience and the literature from FIT implementation programs, predominantly in England and Scotland. We've developed a draft audit tool that could be adapted by services. We've also, as part of our Delphi process, developed research questions. These are the 5 top research questions. We want to try and understand better about how FIT might impact on survival and other critical outcomes, whether FIT might impact on the stage diagnosis, because we believe that patients are more likely to be diagnosed at an earlier stage because we're applying an objective test. How we can combine FIT with other biomarkers. As I said, there's an NIHR program going on at the moment, supported by a health technology assessment program. Whether a second or repeat FIT test, we need to refine this a little bit. Maybe this may form an important part of the safety netting pathway. We need to try and refine safety netting pathways in general, where there's a lack of evidence. Just skip past this. I just want to finish with some comments from Bowel Cancer UK's website. This is the response of patients to this guideline, and we can share these slides, I think, so you can have a look at these. But there has overall been a very good response by patients to the guideline through the Delphi, by our lay membership. And it's very strongly supported by Bowel Cancer UK and other UK charities. So I'll just finish there. Thank you very much. And I'm sure there are probably a whole bunch of questions. Maybe not.
Can you hear me? Yes. Hi, Kevin. Thank you. That was fantastic. I have tried to collate all the great questions.
All right.
So I'll run through them for you. I think some are covered, but if anyone wants to come in and add to what I'm saying, please do. So there was a question, I think this was around the initial study presented on FIT negative, so found 1 in 10 had cancer.
Yeah.
Did you want to come back to that?
So as I said, we don't use the term FIT negative because they may have a detectable FIT level. That's one reason, so from a scientific perspective, but also it implies that there's FIT is a sole arbiter. So a FIT below threshold, and I think that's an important question. I think that, just to reiterate, if someone has a FIT level, a FIT threshold or FIT concentration below 10, then they're no more likely to have cancer than someone who's asymptomatic. That's the bottom line. And we should be trying to encourage people to participate in the bowel cancer screening program who are asymptomatic. Obviously I haven't really talked about resources or how, but it is an important part of this. We have to apply our limited resources most effectively and more precisely to identify those patients who are more likely to have cancer. Bottom line is that no test is perfect, but FIT is a really excellent test, and we have to probably be systematic about applying it and not exclude patients if they have a FIT concentration less than 10, but they can be handled in lots of different ways.
A question from Rob. What about in young patients with PR bleeding symptoms? Our experience is that there are many questionable 2-week rate referrals for young patients with a history consistent with anal rectal bleeding who have a positive FIT. Should they have had this in the first place, or would direct access flexi-sig be better?
If someone has persistent PR bleeding, they can have a flexible sigmoidoscopy. However, as I said, more than 70% of patients who have a FIT will have a FIT below threshold and do not need to be referred. And currently, a lot of patients, there's a huge amount of variation around this in the country. I've been informed by Robert Logan and others at NHS England. In my experience, in London, typically people end up with a colonoscopy, and in other parts of the country they have a flexible sigmoidoscopy. So there's significant variation. Actually, some patients will need a colonoscopy or equivalent CT scan if they have a FIT above threshold. But if the bleeding is persistent, then the sigmoidoscopy tends to detect any cancers where and this is from data from FIT implementation studies. So the cancers that were not detected with a FIT below threshold were in patients who had persistent bleeding, were in the rectum and sigmoid. So therefore sigmoidoscopy is a reasonable approach in those patients. And obviously patients will still want to be diagnosed as to the cause of their period bleeding, and they may want to have their hemorrhoids managed, of course, and that's a reasonable expectation.
So I can see some hands go up, but I'll work through the questions we've had in the chat and then come to those. So there was there's a few questions actually around the concerning symptoms under 10 and what pathway to send on, which I think you did cover, Kevin, around routine, non-site specific. I know someone put into the chat. I guess this is clinical decision making.
Yeah, as I said, if someone has, someone's having a fit because they've had period bleeding and they're 30-year-old, for example, I mean, it's obviously an extreme example, the fit's below threshold, they're almost certainly not going to need to be referred if they've had a few episodes spontaneously resolved, as happens. And these are patients who would be currently managed in primary care, so it's not really a significant change in practice for many of these patients. But this is, as I say, it's one example, and this is a really heterogeneous population. And if the hemoglobin, once again, if they are an 80-year-old and they have a hemoglobin of 110, and it was 108 2 years ago, and have a fit below threshold, once again, I think that it's reasonable for this patient to be managed in primary care. And what we have is an objective test, which actually can reassure us that this patient is really unlikely to have a diagnosis of cancer.
What about patients with change in bowel habit, abdominal pain, weight loss due to a different cancer, for example, ovarian or pancreatic, and do we need to cover that in the guideline?
So I think that's a very important question. This is a guideline which is designed to work out how FIT can be applied for the diagnosis of colorectal cancer. And of course, patients with other symptoms may well have cancers at other sites and can be referred to other cancer pathways as per existing NICE guidelines. And we've also not created a guideline for the management of diarrhea. There's already a guideline for that, or for anemia or whatnot. That would be beyond scope of any guideline to cover the whole of all of this practice in one kind of guideline. It wouldn't be appropriate. So I think that there are existing guidelines for how patients could be referred on alternative pathways.
Please, could you go over the IDA position, as I had thought that this needed to be borne in mind as more likely to give a false negative. Is the recommendation that this doesn't need to be considered in the guidance pathway? We currently exclude this in our pathway and ask for a 2-week referral, even if it is under 10.
That's a very important question. In fact, the data does not bear that out. And I think that there was some early data from the early FIT studies that suggested that some of the patients where the FIT was below threshold had iron deficiency anemia, and therefore those with iron deficiency anemia should be referred. However, this is really based on anecdotal level evidence from some of those early studies and some subsequent studies. If you actually look at the sensitivity and specificity of FIT in people with iron deficiency anemia, it's equivalent to those who have other reasons for referral, for example, a change of bowel habit, or abdominal pain, for example. So it shouldn't be treated differently. Obviously we recognise that was something that would probably be a change in practice.
That's it. And then a question around, so NICE accredited group and approach, or is it a NICE endorsed guideline? It's important to GPs, especially to sessional or locums, that this is confirmed.
Yeah, well, so NICE are commencing their guideline process and whatnot. I think one of the pieces of information they're waiting for is this HTA NIHR assessment to see whether or not there could be a more complicated way of selecting who might or might not be referred, or whether we could refine what we have developed. But essentially, our guideline is follows a NICE endorsed process, and BSG guidelines are used by NICE to develop quality standards, for example. For example, the recent colorectal cancer guideline used BSG guidelines, at the moment there is no other guideline for how we should use FIT in the symptomatic population, really. And therefore, if we don't use any, we don't have any standardization, then people are doing all sorts of different things in all kinds of different ways. So this is a starting point. I think it's a good starting point. It will be developed further. I think that now actually GPs do have some backing for how they should use FIT in practice that they didn't perhaps have before.
Yeah, and I would add to that as well. I know we've had a lot of questions around this, but the use of FIT in this pathway is also in the NHS operational planning guidance and in the PCN DES for this year. So I know a lot of you will be aware, and we'll link to those guidelines. There's one from Stephanie. Has there been any modelling of the increased activity that the bowel hubs would need to create to implement FIT? I can probably take this one, Steph. So in general, the overall vision for FIT is that this work in symptomatic will free up space to allow us to extend the screening programme to those aged 50 and also to enrol people with Lynch, as you point out. We are looking at that nationally. Obviously, we're kind of at the maybe early journey of implementing FIT, so we're keen to not overemphasise what that releasing capacity might be, but actually we're seeing this as a positive for screening, and this is where we want FIT to be implemented so we can really extend the screening programme rather than add any burden by the use in symptomatic. So I hope that answers the question around the impact on screening. I now haven't been in the chat box for a while. Should we take some questions? John, I think you've had your hand up for a little while. John Painter.
Hi, Kevin. Hopefully you can hear me. Thank you very much for your talk. I just wanted to emphasise, clarify something, because different people appear to have taken a different message from one of your slides. My understanding is if you FIT look below threshold, then it's a 1 in 10 chance of missing a cancer if a cancer is present, but your individual risk as a patient is, if you're the individual patient with that low threshold, you have about a 1 in 1,000 risk of actually having cancer. I think some people misinterpreted your slide and thought 1 in 10 people will have cancer if they're below threshold. Have I interpreted it correctly? You're
absolutely spot on, absolutely. So the 1 in 10 is a relative risk if someone has a cancer, as you say, but the absolute risk or the likelihood of an individual having a cancer is about 1 in 1,000. Absolutely. And that's the same as someone who's asymptomatic of the same age. So no, thank you for, I think it's important that that is absolutely clear.
There's a question from Abby. What is your experience of missed rectal cancers with CT colon?
Well, I'm very fortunate that we've got a really great CT service that was set up by our radiologists at St Mark's, and I recognise I haven't worked at DGH's in West London, that access is not so good, but David and colleagues have produced really good evidence from not just single center evidence, but multi-center, large kind of data series that indicates that CT is equivalent to colonoscopy for the detection of rectal and colonic cancers. But there is an element of expertise. A radiologist needs to be able to interpret CT colonography, and that's important. And one of the other pieces of work that David is doing is about training radiologists so that they feel comfortable reporting CT colonography, because they need to obviously learn the technique if they haven't been using it, or perhaps they've only been using it sporadically. But I would feel comfortable if it was my mother and and she had a CT colonography instead of a colonoscopy, definitely.
There's a couple of questions I can answer. So Ian, around plans in place to get NICE approval, endorsement of these guidelines. I think Kevin's covered NICE's role in the BSG guideline, but let us know if not. NICE themselves have confirmed that they're looking at NG12. They've opened a review into FIT use, so they've set out the timelines expecting to be published next year, and they've put into that when they opened that they will be using the BSG guidance to inform, and that they'll be using this ColoFit study, which is the NIHR study around the risk tool. So we are expecting that to happen and working closely with NICE to make sure everything's aligned. But Andy, to pick up your question, we are very much expecting sites to be implementing FIT now in line with the BSG guidance. We've included it in the operational planning guidance, as I said earlier, and in Cancer Alliance plans and within the PCN DES. So the direction of travel from NHS England is definitely to support implementation of FIT now, with the view that NICE is coming and we're working with them.
Okay, thank you.
So I don't know if someone wanted to come in.
And that's the same in Scotland and Wales. Actually, they've kind of started to implement the guideline, and we've been speaking to the NHS bodies in those nations as well.
John, did you want to come back in?
Yeah, sorry, I just wanted to stress Kevin to the question outside the remit of the guidance. Sorry, mate. Did you, when you've gone through all the papers, is there any data linking FIT to the incidence of upper GI cancer? I know it's outside the remit of this guidance, but does it also bode well for us not to have to scope people urgently on the upper GI tract?
I couldn't say hand on heart that we could say that we could rule out an upper GI cancer. There is some data that suggests that if you have a FIT above threshold and a normal colonoscopy, that your overall mortality is increased over, longitudinally in the next few years due to a multitude of different reasons. But it's not really, I don't think there's robust data that suggests that we could avoid upper GI investigation in patients.
Thank you.
Thank you.
Victoria, can I just ask you to come on and clarify your question around the incentive, because I should be able to answer that for you. Are you there, Victoria? I just want to make sure I'm answering the right question.
Hi, sorry, I am here. Apologies. Yes, I guess the question was around, we were on a call last week, and the question that we were asked was if primary care are now expected to undertake their referrals in line with BSG guidance, how does that affect their payments in terms of compliance, in terms of how the patients are being referred in? Because obviously they're currently doing it via the NICE guidance, which has the kind of 5 exclusions, and they move to the 2 exclusions. How, obviously, but I think you've kind of clarified it that you're expecting us to move to BSG. So I guess potentially there may be a dip in performance before we see that increasing again. So we'll have to ensure that obviously primary care, what you're going to count within those acceptable FIT compliance will change. So I think it's just to flag that.
Yeah, that's really useful. So the incentive is based on the people implementing the BSG guidance. So the thresholds reset at 40 to 80%, and the 80% upper threshold reflects that we expect the majority of 2-week rate referrals to have a FIT attached. And we've kind of added that 20% barrier mainly due to patient compliance. So we're expecting GPs to be following the BSG guidance. And also the incentive really was there to get local pathways amended as well. So we have had a lot of questions around we're following local pathways, but we're looking for those to be updated in line with the BSG guidance.
Yeah, I guess just to flag, because I think as an alliance we were previously counting that position based on the NICE guidance in terms of including the 5 exclusions. So but that's noted now, so we can pick that up as an alliance. Thank you.
So I've got another hand. Can you see who that is, Kevin?
I just put the paper in on the chat because it's being published in Gut now. There was a brief version that was available with the key statements a few weeks ago. But if you wanted to look at the evidence in more detail, I think Studi asked a question about the meta-analysis that Brian Nichols have produced. Then it's within the paper along with all the other evidence.
Hello, Amelia. Nice to see you in person.
Hi,
Gonna come in.
Yes, thank you very much, and thank you, Kevin. That's really incredibly helpful, clear advice for what we do with the BSG guidance. That's really, really useful, and I think the BSG guidance is going to help us a lot in implementing this. And I think the clear message is that somebody who has got a FIT of less than 10 does not need a colonoscopy to rule out a colorectal cancer. They may need other pathways depending on other symptoms. But the question for me really is this is quite a significant culture change. And as you can hear from the conversation, there is anxiety about the fear of recriminations for missed cancer diagnosis. And for me, in order to implement this well, we need secondary care to lead the change and to not do colonoscopies on people who have a FIT less than 10. So amazing primary care engagement on this call, as you can see. But my question really is, what work's been doing with secondary care for them to lead this as a change in culture?
Sorry, what was the? I was reading comments. Sorry, at the very end of what you were saying. Sorry, you're asking.
So
You're asking me about culture change, or?
Well, what I'm saying is that really this change in culture needs to be led by secondary care.
Oh yeah. Sorry, yeah. That's not one for me, really.
Nice to see you're paying attention, Kevin.
Sorry, I was just trying to.
But I can come in Amelia's side. So I think this is a really key question, and it has come to me a lot around this kind of ask for primary care to hold the risk, but actually are secondary care willing to take that risk when they're still scoping under 10s. So it's something we are looking at nationally. So what can we put out? Because I think some of this is around cancer waiting times guidance and understanding of when a secondary care clinician can discharge from the urgent cancer pathway. This is also around culture change. So I guess there are some pathways being developed for secondary care. So I know Cheshire and Merseyside have just developed a FIT negative pathway with very clear advice on what the secondary care can be doing and who they should discharge. I think we'll look to do something nationally to very much support that position and make sure we are doing more with secondary care. But I guess just to say, completely recognise that also needs to be something that's focused on, and we're looking for data as well to actually start tracking how many colonoscopies are being done in under 10s, so we can actually go in and say and work with those sites to see how we can address that really and work with the teams. Yeah. We are seeing some really exciting evidence from places like the Northwest where they're seeing the same number of cancers with fewer colonoscopies, and that is due to real senior vetting, but we know that's not happening everywhere.
Yeah, I mean, we can't expect primary care to adopt a change that secondary care aren't comprehensively implementing themselves. So that'd be really brilliant. Thank you, Emily.
So I'm really losing control of the order, but Chris, do you want to come in first?
Yeah, I'm a one-time gastroenterologist and now regional medical director in the South East. I do agree that it is really for secondary care to lead the way in this. And I would just mention that there are a lot of perverse incentives around who gets colonoscoped. There's obvious medical surgical misalignment often in what the thresholds are between different specialties, but in particular there's the private practice pressure to do lots of colonoscopy, particularly in the southeast and London. And I think we have to make sure that everybody's practice is aligned in every quarter, so that, as a general rule, patients with FIT less than 10 do not get colonoscoped except in extenuating clinical circumstances. And that way, one can change the standard. I think the difficulty will be if it is a heterogeneous interpretation and implementation of the rules. And the other thing is that for primary care to take the risk, I've heard time and time again, you've probably mentioned this, that they want to see it in NICE guidance. And I know you've talked about that before I joined the call.
Well, I think this is a good starting point, and will be, I think, this is a standard that will be slightly altered, I guess, through subsequent iterations of the guideline, and because I think the evidence is there, and as I say, we followed NICE endorsed procedures in terms of evidence review and robust methodology. That I think that this is something that is likely to be, it's here to stay. In fact, most of the country is already doing a version of this, but hopefully the standardization will allow people to have the confidence to approach this in a more objective way, I suppose, and rather than excluding certain populations from FIT testing, for example, those with iron deficiency anemia.
Sonia?
Hi, thank you, Kevin. A really good presentation. Just 2 points. Just one, I absolutely agree that to lead the way, especially with the FIT below threshold, we need to ensure that they just don't automatically go into a vague symptom pathway. I mean, that is just wrong on so many levels, that it is a clinical judgment and a triage. And then the second point, you've highlighted the absolute risk and the relative risk, the 1 in 10, 1 in 1,000, and the sensitivity of 87%. And what would be really nice is if you could just explain, because I think you mentioned your mum, that you would be happy for you. How would you explain to your mum, if you had a patient in front of you who doesn't have ongoing any red flag symptoms, and you just want to end the consultation in primary care, somebody who is fit below threshold, how would you explain the figures that you've highlighted?
I always use my mum in consultations with patients, just to give them the confidence that this is not a resource issue. This is about best clinical care. I'm not suggesting that is a standard approach, but Mrs. Monaghan would be getting a hard time probably up and down the country otherwise. But I think this is something that, it's just a test, and GPs are already using their clinical acumen to make decisions all the time about such patients. Many of them will have low risk symptoms, but I think that this what previously have been called low risk symptoms, but now actually we have something which is better than that and more likely to identify someone probably at an earlier stage. For example, we know from in the younger population that people tend to go to primary care 5 times before they're referred for an investigation with symptoms, because it's an impossible task for GPs to objectively assess who's likely to have cancer or who isn't. But here we have a tool that we can apply, and it's also really rather reassuring, because you can say to someone that the likelihood of them having cancer is not higher than it is for your mum. My mum, who's perfectly well, doesn't have any bleeding. I'm not suggesting that my mum would want to be. I'm not suggesting that you use this, but essentially the person that comes with them to their consultation is no more likely to have cancer than they are. But if they have bleeding, they probably want to know why that is, and they may need an examination to see if they have piles. Or it may have been minor bleeding that doesn't require any further investigation or examination, because it's
So are you suggesting, or that rather than talk about absolute risk, relative risk, sensitivities, you could say to a patient who doesn't have ongoing red flag symptoms that your FIT result is below 10, it is unlikely you have a cancer. Your chances of cancer are the same as the general population who are asymptomatic.
Yeah.
Would you be happy, primary care use that analogy?
I think that should be exactly used, almost those forms of words. Some patients will be reassured by that. Some patients will, just be happy to know that, but obviously there will be some anxious patients, and, we have to nuance how we approach this in similar ways that we do with other forms of communication. But essentially that is almost exactly the kind of form of words.
Brilliant, thank you.
Thank you, Kevin, and thanks to everyone for all your great engagement today. This has been really popular, so we've recorded it. We'll send the slides, but I think it might be worth us thinking, Kevin, if you're happy to, putting on another session. Just really quickly to address the last question around medical legal position. In short, this is our response. This is now the BSG guidance position. This is in the NHS operational planning guidance. It's in the PCN DES. We're pushing Cancer Alliances to do it, and it's mentioned in the elective recovery letter that went last week with cancer as a priority. And I mean, and now NICE have released guidance to say that they are going to be updating NG12. So I'm sure that there's still going to be questions around kind of what would happen, but that is our response, and it is now covered in a lot of guidance that this is the position people should be taking. I'm very happy to follow up any questions, or if people wanted a further conversation around what I just said, I'll put my email in the chat, and hopefully if anyone's got any clinical questions, Kevin, I can forward on as well, and we can carry on the discussion. But thanks again for attending, and I'm sure we'll see you all soon.